All right, can everyone see everything? You know what, actually, I need to change the screen I share. 1 second. Huh. Whitney, do you mind unsharing me so I can reshare? Thanks. That's better. Okay, can everyone see what looks like a slide presentation? Okay, great. So I'm just gonna quickly look through this gallery to see who I'm talking to. All right, great. So my name is Sarah Sanghavi. I'm one of the nephrologists here. I work at the VA. I'm also a critical care attending. So if during your rotations you have any questions about either, I've put my email address right here. Feel free to contact me. I tend to be pretty responsive over email. Today we're talking about chronic kidney disease, generally chronic kidney disease that you may see in clinic. I have a few slides that just provides an overview, and then the rest of it's all case-based. So at that point, feel free to use the chat box or just talk between sips of coffee and bites of breakfast. It's supposed to be interactive. I've done this once over Zoom and you guys were amazing, so I expect the same. So we'll just get to it. All right, so first, what is chronic kidney disease? So it's really a syndrome. It has a host of signs and symptoms that make it up. And one of the important parts about why we call it chronic kidney disease is we tend to think of it as irreversible, whereas acute kidney injury, we think of as a reversible process. So when we look at ultrasounds of patients with chronic kidney disease, they tend to have smaller scarred kidneys. If we look at pathology of someone who has chronic kidney disease, we tend to see a lot of fibrosis. And that indicates to us that this process is not going to reverse, and we need to start thinking about the future. It is progressive and tends to evolve over the course of months to years. Now, I guess to follow a strict definition, it would be 3 months of a decreased GFR or other signs of kidney damage, which we'll go into. So 3 months is your strict cutoff, but generally we tend to see it over months to years. And what are the leading causes? So no surprise, this is data from the US Renal Data System in 2017. And the main causes are going to be diabetes and hypertension, which account for almost 75% of all cases of chronic kidney disease. You'll also see some cystic kidney disease, some glomerular disease, and other in there. And other tends to be congenital abnormalities that result in chronic kidney disease. So these are the 5 stages, which you may see in our notes if you're seeing patients in your clinic that have been to kidney clinic. And feel free to use them yourselves just to describe kidney disease among your colleagues. So above a GFR of 60, you have to have some other sign of kidney damage to be denoted as chronic kidney disease. And those tend to be proteinuria and hematuria. So even if your GFR is greater than 60, if you have proteinuria and hematuria, you still have chronic kidney disease. Generally, a normal GFR is somewhere between 90 to 120. Once you fall into stage 3 chronic kidney disease, so that's a GFR anywhere between 30 and 60, we start to think that complications are possible, and we'll talk about those here in a moment. Once you get below a GFR of 30, that's where complications really become evident, and we expect to see them. That's also when we want those your patients referred to our clinic, because we need to manage some of these more difficult specialized complications. At below a GFR of 20, you actually also qualify for the transplant list. And so that's a time for us to start talking to patients about that and considering referral to transplants. Below 15, and again, not a strict cutoff because CKD is a syndrome with signs and different symptoms. But below 15, we definitely start talking about some sort of renal replacement therapy to see if that's within our patient's goals. And it's not just hemodialysis. Peritoneal dialysis is making a comeback here in the US. And so that's something that we tend to talk them through. There's no mortality benefit with either. It's just really a lifestyle preference. So a lot of those conversations are ongoing once their GFR falls below 15. And there's no strict cutoff when we start dialysis. It really tends to be when the patients are feeling bad and when they feel ready. All right, so this is just a busy, horrible slide, which I know it is, and I added in yesterday on purpose for that reason, about calculating eGFR. So we at University of Washington at Harborview use something called the CKD epi equation. It's a newer equation that was developed in 2009. You may have trained with an equation called the MDRD equation, which came from an older study. This one used 8,000 patients from multiple studies to try to derive an equation that was most consistent with actual iothalamate clearance. So when we use creatinine to guesstimate your eGFR, we use a number of parameters put into an equation, but we're not actually measuring anything. So their gold standard was measuring it by iothalamate clearance, which is not secreted or reabsorbed. Whereas creatinine, even though it usually is produced at a steady state, at low GFR, some of it can be secreted. And without actually checking creatinine clearance, like a 24-hour urine, we're running into issues with some people being higher creatinine producers than others. So we use the CKD epi equation. The actual equation does have a race coefficient. UW and Harborview have recently removed, or when they started using CKD epi and moved from MDRD, they're no longer using the race equation. That's been a national, I would say, push recently. So I know Vandy was probably one of the first ones to get rid of it. UCSF has gotten rid of it. Brigham Mass General has now gotten rid of it. And then I know a couple of other New York hospitals that are moving away from the race coefficient. And the main reason for it, one, is that it was never based on great data. So you can see that in their validation cohort, only 10% of people were Black, even smaller for every other race and ethnicity. And the other big reason, probably the more important one, is that race really captures a lifelong social experience. It's not equal to ancestry and it's not equal to genetics. So it really doesn't tell us anything about biology. And we think that creatinine secretion and reabsorption is really a biological phenomenon. So just so you guys know, we use a different equation here than you may be used to using, and these are the reasons why. Also, feel free to interrupt me if you guys have questions about any of the stuff I'm saying. All right. I'm going to try to find my chat box to make sure I have not missed anything. Or someone can tell me if I'm missing anything in the chat box. No? Okay. All right, so just quickly, thank you. So quickly, just to go over types of proteinuria, because when I go through cases, this always comes up, so I've added this in also. So one of our first types of, or one of the types of proteinuria you may see is glomerular proteinuria. What does that mean? That means albuminuria. The thing to know about the urinalysis is that it only includes albumin. So if you have any type of other protein, that UA is not going to pick it up. And I emphasize that because even after my nephrology fellowship, I made this mistake and I felt like an idiot for it because I was a board certified nephrologist and I assumed someone didn't have proteinuria because I saw a negative UA. So don't be like me. The other type of proteinuria is tubular proteinuria. So some of the proteins that get filtered through the glomerulus and do not leak out, so they get reabsorbed, can be secreted through the tubules, and you'll see evidence of tubular proteinuria in people who have tubular damage, so people with ATN or tubular interstitial diseases. That tends to be less than 1 gram of proteinuria per day, And again, you're not going to see it in the urinalysis. It's only if you get a dedicated urine protein to creatinine ratio. The last one's overflow proteinuria, and I've got a picture of CAS nephropathy here in a patient with multiple myeloma. So that's when you're making so many excess proteins in the blood that even though your kidneys are doing what they're supposed to do, which is filter and reabsorb and degrade, some of them pass into the tubules. And when they do, they form these little casts. So this is CAS nephropathy overflow proteinuria. Again, these two will not show up on your urinalysis, so it's good to have a healthy level of suspicion for patients who may be complaining of frothy urine or may have edema or may have none of those things, but their kidney function is getting worse. It's probably worth checking urine protein to creatinine ratio in addition to your urinalysis. So just to recap, urinalysis tells you about albumin, tells you about glomerular proteinuria. Urine protein to creatinine ratio will tell you about tubular proteinuria and overflow proteinuria. Everyone good on that? All right, thanks. I appreciate the nodding, just so you know. I hate this, by the way. I hate Zoom. All right. So general medicine clinic. So here we are. We're going in the cases, and this is where I beg of you to speak to me. Otherwise, this is going to not go well. All right. So these are real cases that I saw. I changed their initials. So this is GI for my GI Joe because I'm here at the VA. So this is a 37-year-old man who's just out of the service. He's found to have a creatinine of 1.46 on routine labs. This is his whole BMP. He says he was told he had kidney disease before, but doesn't really know much more about it. So what is your workup for someone like this? I promise I won't call on people, I think.
Can we start with the UA?
Start with the UA, great. Hold on, I'm gonna see who said that. Was that Kim? Okay, great, thank you, Kim. Yeah, so you wanna see, are there any other markers of kidney damage that make me think this is real or this is bad? So you're gonna be looking for hematuria and proteinuria. You could also look for white cells if it's gonna clue you into some sort of tubular interstitial process. So I agree, that's where I would start too. And oftentimes when I get the consult through the computer, I'll tell the primary care doctor or practitioner that, hey, can you just get a urinalysis? And if there's any, or get a urinalysis first, and then I'll look it over and determine if he needs to be seen in clinic. So this person had a urinalysis, completely normal.
Get a protein ratio.
So you said, well, I get a urine okay, good job. Yeah, so urinalysis can be normal. That's perfect, but they still might have proteinuria. Actually, here's where I goofed up again, because to be perfectly honest, full disclosure, I actually didn't get it. But had I gotten it, I would have told you it was normal as well.
Maybe get a renal ultrasound?
Yeah, so this is a great thing to think about, right? This is a 37-year-old person. I think the first thing that strikes you is that this person's young. So why does a young person have an elevated creatinine? Could it be some sort of congenital abnormality? I'll tell you, if a person has one kidney and is otherwise healthy, there shouldn't be any reason for an elevation in creatinine from just having one kidney alone. However, one kidney coupled with anything else can definitely cause an increase in creatinine. He had 2 normal appearing kidneys on ultrasound.
Is it worth on this person like getting a 24-hour creatinine clearance?
Yeah, so tell me more about why you're thinking that.
I'm just thinking like if their steady state is higher, like if they're producing a lot, but they're excreting an appropriate amount.
Yeah, so great. And whenever, I think this is also just because I work at the VA and I get a lot of, my main patient population is older people in their 70s. So when I see a 37-year-old, the first thing I am is skeptical. And I'm like, yeah, I don't believe this. And the other reason I don't is because when you're in the Army or Navy or Marines, you tend to be in really good shape, tend to have more muscle mass than someone, than another 37-year-old person. So that's exactly it. You'll notice that all the other kidney markers were normal. His BUN is normal. which can happen. Creatinine tends to be better than BUN in assessing kidney function. But when someone has a normal BUN and an elevated creatinine, I always kind of wonder, like, all right, so you really have kidney disease, or are you just kind of jacked? And this guy was kind of jacked. So he just had a lot of muscle, and he was producing way more creatinine. So if you get a 24-hour creatinine clearance, you'll find out that in your urine, instead of making 1 gram of creatinine per day, which is what most people would make, 1 to 1.5, he was making about 2.5 to 3. So he was producing more creatinine, but also excreting more creatinine. So his filtration was completely normal. He just has an elevated creatinine in the serum, and that's perfectly fine. And so this just kind of goes to tell us that our measures of kidney function are somewhat archaic, and it would be very nice if we had a better way of saying this is your GFR right now, and we don't. So we really use a marker that should be produced at a certain rate in all people, but isn't. And if you have more muscle, you're going to produce more of the marker. If you have less muscle, you're going to produce less. So that was all it was for him. The other thing I would remind you guys to ask, especially if you see fluctuations in creatinine up and down, is if they're taking creatine supplements, especially in our younger people who work out a lot, they tend to do that. I also ask about CrossFit, just because that usually opens up a conversation into their workout habits and their supplements. So yeah, that's it. So you get the requisite stuff. You could also have just started with a 24-hour urine creatinine if you had a high degree of suspicion. Alternatively, we have another measure of kidney function that's better than creatinine called cystatin C. And it's better and worse in different ways. So it is affected by inflammation, but it's not affected by muscle mass. So if you saw an outpatient who looked pretty healthy, didn't have any like bad inflammatory conditions, wasn't hospitalized, and you thought he was just a high creatinine producer, you could get a cystatin C, plug that into an equation, and it would have been normal. Great. Any questions about that case? All right, we'll move to the next one. Good work. All right, here's another gentleman. So this is case AL. He is a 73-year-old veteran with osteoarthritis, psoriasis, gout, and hypertension. He's on diltiazem, 180 milligrams only. He does not have diabetes. His albuminuria was checked and was 410 milligrams per gram 1 year ago. And now it's 125 milligrams per gram. A creatinine is 0.7. This person came to us, I believe, because the primary care provider said, do I need to do anything else? Like, what do I do with this person? What should I be worried about? It was actually a non-visit consult, which is some of the things we do here at the VA, where they don't think the patient needs to be seen in person, but this is a question that they have, and a pretty valid one. So what do you guys think about the albuminuria? What could be the cause in this particular patient?
Could it be like a multiple myeloma or something?
I'm looking. Oh, there we go, Erica. Sorry, I've got you guys in like a little column over here. Could it be multiple myeloma? So there's albuminuria. So it wouldn't be, because it's albumin, it tells me there's a glomerular process. It could be, they could have multiple myeloma, but I wouldn't give them the diagnosis of cast nephropathy because that tends to be a tubular process. But they could have multiple myeloma with amyloidosis or light chain deposition disease. I would say that the fact that it's decreasing over the course of a year makes me feel a little bit better that I'm not missing a cancer. But there'd be no harm in checking a urine protein at creatinine or checking an SPEP and free light chains to ensure that a 73-year-old man doesn't have something else going on. I think that's reasonable.
I wonder if like he had been started on lisinopril or something in the meantime.
Yeah, so you're like, why did it regress? And that's a good question. So was there something that we did that actually caused his albuminuria to regress? I gotta say that I'm glad that it went from 410 to 125 and not the other way, because then I would have to think a lot harder. This is one of those things, well, it's getting better. How much do I really need to do? But I think it's also just important to think about what are other causes of albuminuria. But I agree, it'd be interesting to know if there was some medication that decreased albuminuria. So ACEs and ARBs are some of those medications. You may also see it with spironolactone. Now we have a new host of medications that can reduce albuminuria, like SGLT2 inhibitors and GLP-1 agonists. So it'd be interesting if he was on any of those. Judging by his history, he has no reason to be on SGLT2 inhibitor, no heart failure, no cardiovascular risk factors, no diabetes. We'll probably find more uses for them soon though. And then does the other GLP-1 agonist you can use just for weight loss alone? So perhaps. The point of this case is really just go over all the other causes of albuminuria. And for this gentleman who had gout and psoriasis, I thought inflammation was playing a role. If someone has an active fever, has just exercised, has heart failure, poorly managed hypertension, is actively or like currently glycemic, or has an infection, you can also see albuminuria there. The important thing with albuminuria is not to worry about it if you see it once. You really need to wait 3 months, and we do give everyone a 3-month period to kind of let whatever acute things happening regress, and then check again. If it's persistent, then you can think of these things. There's no harm in starting these patients on ACE or ARBs. We have no data to suggest that in the absence of both diabetes and 1 gram of albuminuria, that it improves outcomes. But if you think that this person, because of their inflammatory condition, may have worsening albuminuria, one, you can consider treating their inflammatory condition more aggressively, or 2, you can just say, diltiazem is just a really weird first line blood pressure medication anyway, let's switch you to an ACE or ARB. So all of those are reasonable things to do. Any questions on that? All right. Okay, I'm looking at the same people, so I'm moving you guys now. All right, this is a case HM. So a 69-year-old man who has hematuria present on 2 urinalyses 2 months apart. So before they sent me this consult, they actually checked, rechecked, and were pretty certain, yes, this is true hematuria. In June, they had 2+ blood, 14 RBCs, negative protein. In August, they had 1+ blood, 7 RBCs, negative protein. So what's on your differential for hematuria in this patient?
Malignancy.
Malignancy. All right, all the people talking were higher up. Now I have to figure out who's saying that again.
That was Lauren.
Hi, Lauren. Malignancy, what kind of malignancy?
Bladder.
Good, yeah, and that's really the point of this case. And I'll talk about it a little bit more. So if you have negative protein, again, that only means albumin. But if someone has RBCs in their urine, you're really trying to figure out where is it coming from? Is it the glomeruli or anything below it? And that includes the ureters, the bladder. I didn't tell you this, but because it's going on for 2 months, you could also be concerned about some sort of prostatitis or recurrent UTIs, but they didn't have any WBCs, no symptoms at all. So yeah, the first thing to think about when there's no albumin, that there is blood, is some sort of process below the glomeruli. So either ureteral, bladder cancer, or something else. So this person, I actually said, I am going to forward this consult to urology. He needs a cystoscopy. He's 69 years old. He's in that right age group to have bladder cancer. So perfect. Any questions on that? You got to that a little too fast. I'm going to go through these slides quickly. All right, here's another case. This is a 64-year-old man with hypertension, diabetes, comes into actually established care. His initial labs show a creatinine of 2.1. The rest of his BMP is there. You can see those glucose is 237. And our formula spits out an eGFR of 34 mils per minute. So that is between that 30 to 60, so CKD stage 3. And so my question for you guys is, can you differentiate between acute, chronic, or acute on chronic in this person?
Do you have to have another one like 3 months in the past?
Yeah, so that's what I told you initially, right? If you want to call this chronic kidney disease, I need to know that this is not an acute process. The only way I can know that is if it's been going on for 3 months. So I have no way of knowing, and I put in the whole BMP just to see if I could trip you up in some way, because sometimes people think, oh, well, they're hyperkalemic. Maybe this is a type 4 RTA, maybe this is chronic. You really can't figure out anything. Bicarbonate values can be high or low in acute and chronic. Potassium values can be high or low in acute or chronic. So no, I would say I have no idea without knowing a baseline creatinine. And so the first thing I would try to do at this point is get records if he's ever been seen before. And if he's never been seen before, then what can I do to figure it out?
You could do a UA and spin the urine.
Yeah, so that's actually a really cool idea that I had not thought of, but I like it. And I'm sure we did. We have residents in our clinic, and so we tend to spin the urine frequently. But yeah, if you spin the urine and see muddy brown cast, then you have a diagnosis of tubular injury, acute tubular injury. So that would be one thing you could do to say, oh, this is definitely acute. If I didn't see muddy brown cast, I'd be back in the same situation, but I like that idea a lot. So I didn't see muddy brown casts. All right, I'm gonna.
There could be some things that, I mean, they're not like ideal, but suggestive things of chronic things like anemia, like calcium disorders, and like the size of the kidneys. I know they are not ideal, but.
Yeah, so I think, so you're touching on what are some of the complications that you might get in advanced chronic kidney disease. And one of those complications is anemia. Another one can be mineral bone disease, like an elevated PTH. PTH tends to be real bad at it. I used to think it was good, and then I did it enough times, and anytime someone's even slightly sick, their PTH goes up. And it's much more sensitive to changes in calcium than it is to changes in kidney function. So I kind of threw that one out myself. Anemia tends to happen more in CKD stages 4 and 5. So it's, and I had a chart here, but I actually took it out. But anemia, I think, is about 20% in patients with CKD stage 5, but pretty rare to see in CKD stage 4. And if you see it in CKD stage 3, think about another cause of anemia rather than from the kidney disease itself. But yeah, I think if this person had more advanced kidney disease or a GFR that was lower, then things like anemia and I think really anemia, because again, PTH is a terrible marker. So really anemia may help you there. Just note that patients who are sick with acute kidney injury can also be anemic just because they're sick. So I tend to rely on it a little less. But I like that. You're thinking. That's all I want here. I want you guys to be thinking and talking.
You get an ultrasound.
Perfect. I love that idea. So get an ultrasound, because like we talked about, if you have chronic kidney disease for a long time, you're going to have these teeny tiny scarred kidneys. And normal kidney size is about 12 to 13 centimeters. If you see kidneys that are 9 centimeters in an otherwise normal sized person, that's chronic kidney disease. So I do find that to be a lot more helpful than some of these other lab tests that we use. And again, if it's not there, it's not there. And sometimes in diabetes, you tend to have glomerular hyperfiltration. So you actually have bigger kidneys early on before they start shrinking down. So depending on where he is in his course, you may or may not see it. But if you see it, it's really helpful. And honestly, that's one of the things I use to help differentiate it. All right, So I think you covered all the things that I wanted to talk about between acute, chronic, or acute on chronic. Try to get some baseline labs if you can. Try to rule out all the acute things that you can, right? And you can always get a history on this person. Are you taking NSAIDs? Have you been sick lately? Has anyone ever told you you had chronic kidney disease? The other things I tend to ask is, how long have you had diabetes? Because if you've had it for 15 years, chances are you have some level of kidney dysfunction. Doesn't mean it's going to make your creatinine 2.1, but at least it gives me a little bit of better idea of whether you should have chronic kidney disease at all. And the next slide just goes through some of these things so we can talk about it. So look for risk factors of AKI, volume depletion, NSAIDs, any other new meds, recent infection. Ask about medications and blood pressure trends. If they're on 8 antihypertensives, chances are that they have had exposure to high blood pressure for a really long time. If they have retinopathy on their eyes, they may have microvascular changes in their kidney. Have they had previous AKIs? And people who are prone to those tend to be people with renal artery stenosis. What's the etiology? An A1C could be helpful just to figure out what their exposure to hyperglycemia really is. Again, the UACR, UPCR, and those just stand for urine protein to creatinine ratio and urine albumin to creatinine ratio, and the urinalysis, like you guys mentioned. And then the renal ultrasound. It'll tell you if one of the kidneys maybe is atrophic since birth. It'll tell you if they have polycystic kidney disease or prior renal infarcts. And sometimes they have large kidneys that are too large, and those make you think of infiltrative disorders like lymphoma or amyloid or sarcoid. And then, like we discussed, the complications start appearing at CKD stage 3B to 4, but it's really the PTH that shows up at 3B, and you don't start seeing the anemia until 4 or 5. But if we're treating this person like they have chronic kidney disease, we should start thinking about their hemoglobin and their iron stores and their bone mineral disease and check those things as well. The last thing I would say is counsel. And the reason I say this is because so many of our patients come to see me in clinic. And one of the first things I do is ask them, oh, so why are you here to see me in clinic? Very often they have no idea. And then I have to like throw out, so you have chronic kidney disease, and those words are a little harsh, right? Chronic disease, especially for people who otherwise are feeling fine. So it can be kind of a blow. So it tends to work nicely if they get it in like little small nuggets, hear it from someone they trust who's their primary care provider, and then they're kind of braced and mentally prepared to start hearing things from me. So just, it's hard when you guys are managing so many different things, but if you can name what they have, it tends to help them when they come see a specialist. All right, so results for this gentleman. So he had no NSAIDs, no fevers, no vomiting or diarrhea, no diuretics. His calcium was normal. I always check for that, thinking kind of myeloma or anything else that can cause vasoconstriction of the renal arteries. He was on losartan, 50 daily. He recently got started on Plavix after he had a drug-eluting stent placement. And that's not something I typically think about, but when they give me the history, I start worrying about, could this be some sort of thrombotic microangiopathy related to Plavix? It was not. Past medical history, he'd had diabetes for 12 years, hypertension for 12 years. He's never had an eye exam, so I didn't know if he had retinopathy. But generally, 12 years is pretty good for diabetes to have some sort of evidence of kidney damage. When I checked his UACR, he had 1,300 milligrams per gram of albuminuria. His UA had 4 RBCs, no WBCs, 3+ protein. Sugars ran 200s to 300s, and you saw that on his BMP. Blood pressures were actually good, but he said historically they had been higher. And then his renal ultrasound showed 11 centimeter kidneys and no other abnormalities. So at 11 centimeters, a little on the smaller end, and kind of what I would expect for someone who has CKD stage 3 disease, 3B disease. So not super, super tiny and shrunken and not working, but not normal for a 64-year-old man who should have about 12 to 13 centimeter kidneys. And then just to talk about diabetic nephropathy, because this is something we struggle with as nephrologists, and I think the entire world struggles with, mostly because there's a lot of diabetes globally, and kidney biopsies are invasive procedures that are not without risks. And so oftentimes we're trying to figure out, do I biopsy a patient with diabetes, and how do I determine whether this is a typical course for diabetes or not? So unfortunately, a lot of our data from about diabetic nephropathy comes from patients with type 1 diabetes, and people with type 2 diabetes don't necessarily follow that same course. So they can have variable amounts of albuminuria, and they can have hematuria. Again, it's a glomerular disease, and so you're allowed to have a little hematuria, even though typically we don't think of that when we think of diabetic nephropathy. From a few studies that are contemporary, and the one by Sharma et al. Is only a US population in the tri-state area near New York. So the duration of diabetes, so these were predictors of having diabetic nephropathy, and it was duration of diabetes of more than 10 years if you had type 2, or more than 5 years if you had type 1. Proliferative retinopathy has a 25% sensitivity, but a 98% specificity. So it's very specific for diabetic nephropathy, but just because they don't have it doesn't mean they don't have diabetic nephropathy. Non-proliferative retinopathy, less helpful than proliferative. And then nephrotic range proteinuria, even though we typically think of, oh, you have more than 3 grams per gram, you must have some sort of nephrotic disease like membranous or FSGS, it tends to actually be pretty common in diabetic kidney disease. And we ran those numbers here on our biopsies in Seattle, and the same thing held true. So we do think that you can have no proteinuria or severe levels of proteinuria, and all of that can be diabetic nephropathy on biopsy. So it makes our jobs hard, unfortunately. Evidence against diabetic kidney disease is nephrotic syndrome. So if you have severe hypoalbuminemia and edema, which seems to be related to your kidney disease, that shouldn't really happen in diabetes. It can in about 10% of cases, but it is very atypical. If your diabetes is just managed with orals and no insulin, it means your exposure to hyperglycemia is probably pretty low, and we wouldn't expect a lot of diabetic changes in the kidney. And then if you have a sudden change in proteinuria or eGFR, so instead of kind of having nothing forever or a lot forever, or just a slow increase in proteinuria, if you're kind of 25 milligrams per gram of albuminuria, 25 milligrams, 35, and then suddenly you go to 2,000, that's something that suggests that some new process is now happening in the kidney. Questions on that? A lot of info.
So I just had a question about the nephrotic range proteinuria, but not nephrotic syndrome.
Mm-hmm.
So like you're saying their blood albumin or serum albumin is still normal,
Right.
but they can be peeing out a ton of protein.
Right. And it's
Okay.
weird. And it's not what we've traditionally taught. We usually just kind of throw everything nephrotic range proteinuria into the syndrome. But now that we have so many people with diabetes who have nephrotic range proteinuria without nephrotic syndrome, we're starting to characterize that group of people a little bit better. So exactly what you said, that they're peeing out a ton of albumin, and yet their serum albumin is not low. Seems weird. The reason for it is that your hypoalbuminemia is probably related more to suppression of albumin production by the liver. That's probably the same mechanism. So the liver is also mediating the increase in triglycerides and lipids rather than just losing albumin. Because even if you're losing a couple of grams of albumin per day, that's not enough to drop your serum albumin, which is 4 grams per deciliter, and you got a lot of deciliters in your blood. So we really think it tends to be more of a hypoproliferative, I can say that, low production of albumin in the liver, and other kind of pleiotropic mechanisms that are causing it. And I see that I have a question in the chat box. All right. So one of the questions is albuminuria and proteinuria interchangeable? And I think sometimes we use the term interchangeable. It's kind of like the square and rectangle. So all albuminuria is proteinuria, but not all proteinuria is albuminuria. And that's the way I would try to frame it in your mind. So proteinuria includes all types of proteins, including albumin. Albuminuria is pretty specific to the glomerulus. All right, so we will move on. This is just a slide to show you that hematuria can occur in diabetic kidney disease. This is a study that looked at all different types of glomerular diseases. And again, diabetic kidney disease is a glomerular disease, and looked at the proportion of people with no hematuria, dysmorphic RBCs, so the funny looking ones that we think are from the glomerulus, whether that was less than 25% or greater than 25%. You can see that almost half of patients with diabetic glomerular sclerosis had hematuria, and a proportion of them, smaller, so probably about 10%, had dysmorphic RBCs, so the funny looking ones that we think about for glomerular hematuria. So it can happen. It's not what we consider typical historically, but our ideas of what's typical in diabetic nephropathy have been changing. All right, I do talk about that a lot because you will have a lot of patients with diabetes, but we will move on now. All right. So the other question is this hypersensitive nephrosclerosis? And my corollary question is, can hypertension cause nephrotic range proteinuria? It's a hard question, not a trick question though. If you don't want to answer, I'll take head nods of any sort. Okay, I think lots of shrugs. Any more shrugs? More, okay, got it. So generally, I don't know. And that's totally appropriate because I didn't know before I became a renal fellow either. So yes, and hypertension is a cause of something called secondary FSGS. And I will answer this question in just a moment after we talk about secondary FSGS. So here is a glomerulus that you guys, that might bring back terrible memories to step one. And you can see that, maybe you can see, it's hard to figure out what's ever going on in glomerulus. But these are little capillary loops. And here, they're filled with a bunch of pink stuff. So that's sclerosis. And it looks like it's this little pie slice here. So that is a segmental sclerosis. And then here is electron microscopy, which is super cool and much easier, I think, to read than a bunch of pink. And so these are those same capillary loops here. And you can see that on this side, these little hair-like projections are podocytes. The reason I'm showing you this is just because in secondary FSGS, rather than primary FSGS, and all that means is if I call something secondary FSGS, it's due to something else. Hypertension is the most common cause of secondary FSGS in our country. You can see podocyte effacement in different segments. So here, podocytes are kind of effaced. Here you can see them again. Here they're kind of effaced again, and here. So it's this segmental effacement as well. And that tends to be a secondary process rather than primary. You can't see my mouse. Oh, because my mouse is on the wrong side. I'm sorry. All right. Pie-shaped segmental sclerosis. Sorry, I've got two screens, guys, and I was mousing on the wrong one. And then capillary loops. And these are my little podocyte foot processes. And at some places, kind of like here and here, they're kind of effaced. And then you can see them nice and hair-like in other places, kind of effaced. You might be able to see them a little bit better here. Okay, thank you for pointing that out. And then there's this other question here. How often do you use an albumin to protein ratio in your practice to distinguish between glomerular disease versus ATN? Honestly, the thing I use most to try to figure out if someone has ATN is spinning the urine, because I find that those granular casts tend to have really good specificity. There was a study that was done that looked at if you have more than 5 granular casts, your likelihood ratio of having ATN is 5 times as much. And if you have more than 10, it's infinity, because the denominator, there's no cases of pre-renal in patients who had muddy ground cast. So in general, in the outpatient setting, I'm really not thinking about ATN. In the inpatient setting, I am. And at that point, I'm spinning urine looking for muddy ground casts. In terms of the albumin to protein ratio, which is, and I think you mean the difference between UACR, or urine albumin to creatinine, and urine protein to creatinine. So I use that when I'm trying to diagnose multiple myeloma or cast nephropathy fast, because if I send a SPEP and free light chains, it takes like a week to come back, and this patient may need to come into the hospital and get started on chemo. So my quicker diagnostic measure, and if they're really disparate, basically clinches the diagnosis before you get the SPEP and free light chains, is get a UACR. If it's low, 100, 200 milligrams per gram, and you get a UPCR and it's 7 grams or 7,000 milligrams per gram, you clinched a diagnosis of multiple myeloma. And honestly, one of my first months as an attending, that's what I did. And the person had 34,000, that was their light chains, their kappa light chains. So it was impressive. But it took a while for that to come back, whereas I was able to kind of diagnose them right off the bat with the difference between the UACR and UPCR. Did that answer everything?
Yes, thank you.
Okay, perfect. All right, only a couple more slides. Case PC, 56-year-old who had AKI. So now we're getting to a little bit of AKI, with a creatinine rise from 1.3 to 1.7 after 3 days of diarrhea, pretty good hydration. You got a renal ultrasound just because he never had one in our system. And it showed 5 cysts. Oh, actually, no, because it was an acute kidney injury. That's why. So even though he had a good history for, I had diarrhea, he keeps telling you, but I was drinking a lot of fluid, like this shouldn't be a problem. So you get a renal ultrasound really to rule out hydro or something else that could be causing an acute rise in creatinine. And it shows that there's 5 cysts in the left kidney, 7 cysts in the right. The kidneys are about 12 to 13 centimeters bilaterally. So what do you think about that? Genetic test. All right, Kim's ready to call this something. Kim, do you want to call it something?
Like polycystic kidney disease?
Yeah. So you're saying this is a lot of cysts. And I think the big question is how many cysts are abnormal, right? And that is a difficult question, but at least you're thinking, could this be polycystic kidney disease? So a workup for polycystic kidney disease could be genetic testing. It could be asking for a really good family history if they know it. So polycystic kidney disease occurs in 1 in 400 to 1,000 live births. It's actually a really common genetic condition. Positive family history tends to be the most helpful because it's autosomal dominant, but up to 25% may not have one, or may not know because perhaps a parent died before they were diagnosed or died of a brain aneurysm, but nobody really knew that's what it was, just so died suddenly. There are 2 types of mutations. There's actually far more, but these are the ones that we consider to be the most common. And that's a mutation in PKD1, where the average age of end-stage renal disease is 54, or PKD2, where the average age of end-stage renal disease is 74. So if I were to put this person in a grouping, knowing that they were already 56 years old, it would likely be 56, some evidence of kidney damage, probably one of these slower progressors or PKD2 mutation. But there is tons of variable phenotypic expression and more than 15 different mutations that you can have for PKD1. So some people have it and never have a decline in their kidney function. Other people do. One of the most important things you can tell patients is to drink a ton of water. And if they get dehydrated, that can actually probably show for them. The reason we tell them to drink water is because it suppresses ADH. And we think ADH is actually involved in the pathogenesis of polycystic kidney disease. It's another reason why sometimes we'll use a medication called tolvaptan or any type of Vaptan, which is an ADH receptor blocker. So at this age, 15 to 29, if you should not have more than 2 cysts total. Cysts tend to happen with aging and with kind of decline in kidney function, dysregulation of tubular processes. If you're young, that shouldn't happen. So 2 cysts at all in your kidneys before the age of 30 is abnormal. Between the ages of 30 to 60, 2 cysts per kidney is considered abnormal. And he's had 5 and 7, so definitely in that abnormal range. And then if you're more than 60 years old, 4 cysts per kidney is considered abnormal. And you can see that this is kind of arbitrary, that between 59 and 60, there's so much difference. So just know that this data was kind of developed from patients with polycystic kidney disease and their first degree relatives. Doesn't mean you have to stick to them. If there's something that you think is abnormal, even if they're 59 and a half, or 60, just turned 60, and they only have 2 cysts per kidney, that's still something that you might want to refer them to. So we do like to follow patients with polycystic kidney disease because we have some very specialized treatments that can be used depending on a host of different factors and requires a lot of counseling as well. All right, so I am on time today. So conclusions. Hematuria without albuminuria is more likely to be a non-glomerular source, and you guys got that one really quickly. Hypertensive nephrosclerosis can have significant proteinuria. It's usually if patients have secondary FSGS as a result of their hypertension. Patients with diabetes can have non-diabetic kidney disease, so watch for sudden changes in proteinuria, and that's probably one of the most important things that you'll find to be abnormal. Be suspicious if you find multiple bilateral kidney cysts. And then I didn't get into this for the purposes of time, but GLP-1 agonists and SGLT2 inhibitors are kind of the rock star drugs of 2020. And there's a current cardiology conference happening right now where we're finding even more benefits in the kidneys. So think about those for any of your patients with diabetes and CKD. And honestly, probably in the next few months, really almost any patient, even if they don't have diabetes. So I know you have another lecture here shortly. I might be able to do questions through the chat box, so the rest of you guys can take a break. Will that work? Yeah, maybe. Okay, cool.
10:05, unless you're staying for questions, then factor that in.
Oh, great. So thank you, Kim. I appreciate it. And then good reading resources for the beginning intern. That's a good question. So I know, the resource that I think is probably really helpful, it may be a little bit higher than intern level, but still useful, is if you go to Renal Fellow Network. There are a lot of kind of tutorials about just how to think about urine sediment, how to think about kidney disease. Some of them are probably going to be fellow level, but a lot of them are written by fellows for trainees. And if there's anything that just is too complex, skip over it. But I think I find it to be one of the better med, or I guess I should say kind of foam ed resources on the internet. Any other questions? That was a great one. Oh, I should also, can you repeat the name again? Sure, it's Renal Fellow Network, and you can Google it. I think it's actually renalfellownetwork.org. Oh, thank you. That was great. So Jordan put the URL down there. And then I would also kind of make a plug here, since I have a couple minutes, for doing a nephrology rotation. So we'd love to have you guys rotate with us at any of the 3 sites, so UW, Harborview, or the VA, where I am, so choose the VA. And then we also have an ambulatory rotation that I think you guys should do on your, I think you can do on your track as well, where you rotate with us in the various clinics. So we love to have you guys. We learn a lot from your questions, and it makes us read and be better doctors.
So looking at this website, where do you recommend starting?
You guys can still, let me actually pull it up.
Okay.
Oh, okay. So here's the problem with the VA. It blocks me from it. And just so you know, I'm not lying. So I can't look it up with you guys. But there should be a search function, I would hope. Otherwise, you might be able to just look through blog entries. Some of the things that I think interns find most helpful is just urine sediment, just to get comfortable with looking at granular cast, dysmorphic RBCs, white cells. And let's see. Yeah, and I think it'll also link you to a bunch of other resources as well. But I would play around with it. And sorry, I haven't been to it very recently to be able to tell you much by memory. And clearly the VA does not think it is a good use of my time. Oh, sorry. Okay, Whitney Harper says ambulatory renal is one of the most requested rotations. Good. So thank you, Whitney. So it sounds like no matter what track you are on, you can request it. And people tend to like it. We're nice. We like to teach you stuff. All right, I feel like I should go so you guys actually get some break time and don't feel like you have to entertain me. So thank you for being a wonderful audience, and I will get out of here if I